Teamwork in cardiac arrest. The difference between life and death. Nicole Bryan, RN, Rowan University. As nurses, we work as part of a healthcare team to ensure that our patients receive quality care that results in the best possible outcomes. As part of a healthcare team, it is imperative that there are clear distinctions of one another's role and individual responsibilities so that good collaboration can be achieved. This presentation hopes to explore teamwork and collaboration in cardiac arrest situations and offer solutions to help improve care, leading to better outcomes for future patients. The American Heart Association in 2016 released statistics that updated current cardiac arrest situations in the United States. Over 300,000 cardiac arrests occur in the United States each year out of the hospital. 90% of them die because bystanders do not know CPR. However, in hospitals, over 200,000 cardiac arrests happen, yet the survival rate for adults is only 24%. Healthcare providers are only required to have CPR and ACLS training every 2 years. In the event of a cardiac arrest, rescuers should perform chest compressions at a rate of 100 to 120 per minute. These are known as quality chest compressions. Healthcare providers are encouraged to simultaneously perform steps like checking for breathing and pulse in an effort to reduce the time from the first chest compression. Successful resuscitation requires a leader. It also requires a team that functions as a team, with everyone performing their role seamlessly. The American Heart Association also identifies teamwork dynamics. As the team leader, this person should be organizing and monitoring the performance of the team overall. This person also should be able to perform all the roles that are required and should be effectively directing all the team members. The team member has to understand and identify their role in the code. They also have to be willing, able, and skilled to perform that responsibility and be committed to the success of the team. Critics of the American Heart Association Teamwork Dynamics and National ACLS course say that the infrequency of in-hospital cardiac arrests coupled with the interval of time between provider training can lead to inadequate performance. Roles in cardiac arrest vary from discipline to discipline. For example, a respiratory therapist has a different role than a registered nurse, yet these roles are not addressed in the current ACLS course offered to providers. There's too much reliance on the physician to be the team leader, which can often result in miscommunication and poor performance if the physician is not an effective communicator. Teams do not participate in ACLS courses with members they will be working with during their regular shifts. Some of these criticisms are hard to swallow, especially for healthcare providers who want to provide the best quality care to their patients. So what can we do to improve how we do business? Well, in 2007, nursing leaders at St. Joseph's Hospital in Marshfield, Wisconsin, restructured their hospital's code team. With the use of simulation education and mock codes, team members were kept up to date with the latest ACLS practices and familiarity with one another to help improve performance. Through this process, outcomes did improve. The newly restructured teams were more confident in their skill set and team leadership, and there was a decrease in time to defibrillation. In order to improve teamwork and collaboration in cardiac arrest, I've identified 3 ways in which we can do so to help improve our performance. One way is to assign team members and clearly define the roles. Also, by performing mock codes and simulated education, we can train members of code teams more frequently. We also need to collect data on the mock codes and real codes to weigh the outcomes, and survey team members to see what worked and what didn't work in the situation. Again, let's learn from our peers. The University of Pennsylvania restructured their code teams in 2016 and created a physician nurse diary that placed the physician as the organizer of the code and the nurse as the chief communicator and delegator. They also created a 3-pulse check rundown, which helped identify the nurse leader and team members' roles during the first pulse check. At the second pulse check, team members were given color-coded stickers which indicated their specific role. During the third pulse check, role providers were clearly identified and all unnecessary personnel left the room to prevent overcrowding and confusion. This helped to optimize patient care. As we work to identify roles and create specific code teams, we need to focus on education of those code teams. And there are so many benefits through our research of simulation education. Simulation provides feedback to team members on how they are working together and what can be changed to collaborate and communicate more effectively. It also provides repetition and honing skill sets so that the team members can feel confident in the delivery of their care. It provides a realistic environment and challenges team members to perform as a unit efficiently with the hope of improving the outcomes of future patients. We have an opportunity to save lives in healthcare. By working to improve teamwork and collaboration in cardiac arrest situations, we can help improve the delivery of care to our most critical patients. Identifying team members' roles and responsibilities will help decrease confusion and increase cohesiveness. Frequent education through the use of mock codes and simulation will help keep skills up to date and promote effective team dynamics. And collecting data and identifying challenges and ways to improve will keep our practices more effective and successful. I appreciate you listening to my presentation on how we can use teamwork and collaboration in cardiac arrest situations to help improve patient care. If we work together, we can always strive to be better at what we do and provide the best possible care to all our patients.